The topic of lecture is Medical Emergencies in a Dental Office, the role of the dental nurse in providing first aid. Lecturer Dr. Mariana Levkiv. This lecture outlines most frequently occurring medical emergencies that develop during the course of a dental treatment, and they are as follows: vasovagal syncope, postural hypotension, allergies, hypersensitivity reactions, diabetic emergencies, hyperventilation, asthma status, cardiac chest pain, myocardial infarction, epilepsy, post-extraction bleeding. So what is emergency? An emergency is a medical condition that demands immediate attention and successful management. These are the life-threatening situations of which every practitioner must be aware of so that needless morbidity can be avoided. Life-threatening emergencies can and do occur in the practice of dentistry. They can happen to anyone, a patient, a doctor, a member of the office staff, or a person who is merely accompanying a patient. The occurrence of a life-threatening emergencies in dental office is infrequent. Many factors can increase the likelihood of such incidents, and these include increasing number of old persons seeking dental care, therapeutic advances in the medical profession, growing trend towards longer dental appointments, and increasing use and administration of drugs in dentistry. Emergencies can sometimes be anticipated as a result of having obtained a thorough medical history. Risk management. In spite of all the technology available today, history collecting is still the mainstay of diagnosis. The impact of social, environmental, hereditary, and behavioral factors on patient well-being and illness must be realized in the patient's history. It is therefore recommended that all primary care dental facilities have a process for medical risk assessment of their patients. Anticipation of potential medical emergencies that may arise should be highlighted by taking a thorough medical history, which is revised, updated, and checked each time the patient presents for treatment. It has been suggested that the presence of an updated medical history may help to minimize the risk of a medical emergency occurring. Main reasons of medical emergencies in dental office. More than 54% of the emergencies occurred during or right after local anesthesia. Other two procedures that are closely associated with potential high patient anxiety that can lead to medical emergencies are tooth extraction and pulp extirpation. Incidence of medical emergencies. The most common medical emergencies in dental practices include syncope, adverse reactions to local anesthesia, grand mal seizures, angina pectoris, hypoglycemia, post-extraction bleeding. Myocardial infarction and cardiac arrest are rare occurrences. It is estimated that, on average, a general dental practitioner will experience a medical emergency at least once every 2 years. Vasovagal syncope is the most common emergency encountered. Interestingly, one study showed that 4.8% of all general dental practitioners observed 22% of all syncopes, and that the prevalence of vasovagal syncope tends to decrease with professional experience. The goal of emergency management. Any dental professional can encounter an emergency during the course of their treatment. Every dental specialist should have the knowledge to identify and manage a potentially life-threatening situation. Prompt recognition and efficient management of an emergency by the specialist results in a satisfactory outcome. Though rare, emergencies do occur in a dental clinic. The ultimate goal in the management of all emergencies is the preservation of life. The prime requisite in managing an emergency is maintenance of proper position, airway, breathing, circulation, and definitive treatment. Moving and handling techniques in the dental chair during medical emergency. Although medical emergencies in the dental practice are rare, they can occur and may require safe moving and handling techniques. If the patient is unconscious and breathing normally and in the supine position, the airway is at risk, as for example, the tongue could block the airway. The patient will therefore need to be moved into the recovery or lateral position. For example, if a patient has a major seizure, convulsion in the dental chair, once the convulsive movements stop, it is advised to place the patient into recovery position. If a patient has a cardiac arrest in the dental chair, then cardiopulmonary resuscitation will need to be performed on the patient in the chair. And here it is showed the position of how to provide safe position in the dental chair during medical emergencies. And we proceed and will discuss all possible medical emergencies that can occur to the patient in the dental office one by one. And let's start from the syncope. What is syncope? From the Greek, it means to cut or interrupt. It is a symptom. Syncope is defined as a sudden loss of consciousness associated with inability to maintain postural tone, followed by spontaneous recovery. This is relatively common. What are the reasons of the fainting? Fainting is when you pass out for a short time. Fainting caused by transient hypotension and cerebral ischemia is the most common cause of sudden loss of consciousness in dental office. There are several predisposing factors, but some patients particularly prone to fainting and frequently do so. Fainting is also called, as a medical term for fainting, we have syncope. As well, we can use synonyms: decreased consciousness, loss of consciousness, or passing out. And such anecdotal picture that gives us the reasons of fainting. Factors predisposing to fainting in dental office: pain, injection, fatigue, fear of pre-dental procedures, anxiety, hunger, not eating or drinking enough pre-dental visit, standing up too quickly, and this could be a sign of a low blood pressure, being too hot, being very upset, angry, or in a severe pain, heart problems, taking drugs, or drinking too much alcohol. Symptoms of fainting. Fainting usually happens suddenly, and symptoms can include premonitory dizziness, weakness or nausea, pale, cold skin and sweating, slurred speech, feeling sick, changes to your vision, initially slow and weak pulse, becoming full and bounding, loss of consciousness. Sometimes consciousness is lost almost instantaneously. Minor convulsions or incontinence are occasionally associated. Management of fainting attack. Lower the head, preferably by laying the patient flat, and raise their legs. Loses any tight clothing around the neck. Give a sweetened drink when consciousness has been recovered. If no recovery within a few minutes, consider other causes of loss of consciousness. Important to keep the patient upright worsens cerebral hypoxia and is harmful. Prevention. Regular fainters are frequently helped by an anxiolytic, such as temazepam 5 mg orally on the night before and again an hour before the treatment, but must be accompanied by a responsible adult. And on this picture is described Trendelenburg position during syncope management. So this is a desirable position for the patient to be given in the case of fainting attack. And we proceed with acute hypoglycemia. Hypoglycemia occurs when your blood sugar, glucose, level falls too low for bodily functions to continue. And there are several reasons why this can happen. And the most common reason for low blood sugar is a side effect of medications used to treat diabetes. Not eating enough, postponing or skipping a meal or a snack, if patient prevented from eating at the expected time by dental treatment. Why would hypoglycemia occur if one is not diabetic? Hypoglycemia can occur with malnutrition and starvation when you don't get enough food and the glycogen stores your body needs to create glucose are used up. An eating disorder called anorexia nervosa is one example of a condition that can cause hypoglycemia and result in long-term starvation. Insulin overproduction, it is another reason. And this picture gives you understanding of potential causes of non-diabetic hypoglycemia. So we have certain medications that could lead to hypoglycemia, underlying illness, overproduction of insulin, reactive hypoglycemia, drinking alcohol, hormonal deficiency, and insulin autoimmune syndrome. Signs and symptoms of acute hypoglycemia. If blood sugar levels become too low, hypoglycemia signs and symptoms can include looking pale, shakiness, sweating, headache, hunger, nausea, an irregular or fast heartbeat, fatigue, irritability or anxiety, difficulty concentrating, dizziness or lightheadedness, tingling or numbness of the lips, tongue. Premonitory signs are similar to those of faint but little response to laying the patient flat. Reasons: taking too much insulin or diabetes medication, and not eating enough, postponing or skipping a meal or a snack, increasing exercise or physical activity without eating more or adjusting your medications, and drinking alcohol. Management of hypoglycemia is important. If there is any doubt about the cause of loss of consciousness, insulin must never be given as it can be fatal to a hypoglycemic patient. Management of hypoglycemia. Patient often aware of what is happening and able to warn the dentist. Before consciousness is lost, give glucose tablets sugar, at least 4 lumps, as a sweetened drink, repeated if symptoms not completely relieved. Ideally, if consciousness is lost, give sterile intravenous glucose up to 50 milliliter of a 50% solution. If sterile glucose not available, give subcutaneous glucagon 1 milligram and then give a sugar by mouth during the brief recovery period. Hypostop. This is a medicament. This is a gel containing glucose that may provide sufficient glucose absorbed through the oral mucosa to combat loss of consciousness. And we proceed with circulatory collapse. A circulatory collapse is defined as a general or specific failure of the circulation, either cardiac or peripheral in nature. Although the mechanisms, causes, and clinical syndromes are different, the pathogenesis is the same. The circulatory system fails to maintain the supply of oxygen and other nutrients to the tissues and to remove the carbon dioxide and other metabolites from them. The failure may be hypovolemic or distributive. Reasons, signs, and symptoms of collapse. A common cause of this could be shock or trauma from injury or surgery. Signs and symptoms as follows: pallor of the skin, rapid, weak, or impalpable pulse, at near loss of consciousness or loss of consciousness, rapidly falling blood pressure. As you can see, I highlight these symptoms, near loss of consciousness and rapidly falling blood pressure, in the red color, indicating that these are indicative symptoms of collapse. And this is worth to memorize. Management of circulatory collapse. Lay the patient flat and raise the legs. Give at least 200 milligram hydrocortisone sodium intravenously or intramuscular route can be used if vein cannot be found. To read in detail about management of this condition, you can follow this link. And we proceed with airway obstruction. An airway obstruction is a blockage in any part of the airway. The airway is a complex system of tubes that transmits inhaled air from your nose and mouth into your lungs. An obstruction may partially or totally prevent air from getting into your lungs. Reasons, signs, and symptoms of air obstruction. Air obstruction is usually caused due to accidental slippage, aspiration of foreign objects, or laryngeal spasm. Patient manifests with inability to speak, grasps the throat, and this is a universal sign of this condition. Patients can cough. They have inability to exchange air in spite of respiratory movements. They are cyanotic and could have loss of consciousness. And this might eventually lead to cardiac arrest finally. Management of this emergency condition. Main priority is to clear the airway, but the method differs depending upon whether the patient is conscious or unconscious. If the patient is conscious, then he or she must be made to sit straight, support chest with one hand, and deliver 5 sharp back blows between the shoulder blades with the heel of the other hand. But if the patient is choking, an attempt is made to expel the object with upward thrusts using Heimlich thrust. It acts as artificial cough that produces a rapid increase in intrathoracic pressure and thus helping to expel the foreign body. Pay attention to this picture that shows this process of artificial cough, Heimlich thrust. And let's proceed with the next emergency condition, asthmatic attack. Anxiety, infection, exposure to an allergen or drugs can precipitate an asthmatic attack. The goal of management during an acute asthmatic episode on a dental chair should be to relieve the bronchospasm associated with the attack. Signs and symptoms of asthmatic attack. Patient presents with sickness or heaviness in the chest, difficulty in breathing, spasmodic and unproductive cough, expiratory wheeze, and anxious behavior. Hence, the patient should primarily be relieved of irritants and all particles should be removed from oral cavity. And this picture shows schematic representation of asthmatic attack. Here you can see the broncha, the bronchiole, free normal airway, and bronchospasm, tightened muscle, inflammation, thick mucus production, and constriction of bronchioles. So this is asthmatic airway. What is the management of asthmatic attack? Drug of choice is 2 puffs of albuterol. If no improvement is seen in 15 seconds, then administer 1 to 1000 adrenaline, 0.5 milliliter, subcutaneous or intramuscular, and if still no response is observed in 2-3 minutes, then salbutamol slow intravenous injection is advised. As well, here it is a recommendation of 5-step rule how to deal with an asthma attack. First of all, sit up and stay calm and do not lie down. Take slow, steady breaths. Take 1 puff of reliever inhaler, usually blue every minute. Use a spacer if available. Call emergency care if your symptoms do not improve after 10 minutes. And repeat step 3 if an ambulance has not arrived in 10 minutes. If someone has an asthma attack, do not leave them on their own. Chest pain. Factors that precipitate chest pain include angina, acute myocardial infarction, gastrointestinal reflux disease, anxiety, costochondritis, and paroxysmal supraventricular tachycardia. Patients generally present with tightness, fullness, constriction, or heavy weight on the chest. Angina pectoris and acute myocardial infarction are the two commonly occurring cardiac problems in a conscious patient. Patient's history is of prime concern here. If this is the first time patient has ever experienced a chest pain, then dental specialists should treat him or her as if it were an acute myocardial infarction and have emergency medical service transfer immediately. Excuse me. If not, then it is an angina pectoris situation. Quality of pain can also indicate whether the patient is having an angina or acute myocardial infarction. In angina pectoris, pain is significant but not severe, whereas an acute myocardial infarction pain generally radiates to left side of the body left part. Okay, excuse me, let's proceed. Reasons of angina pectoris. A patient with coronary atheroma might have a first angina attack as a consequence of an emotional response to dental treatment. However, more patients have already had attacks and carry medication. Acute chest pain due to myocardial ischemia is the only symptom. And pay attention, focus on these schematic diagrams that shows the passage of blood through coronary arteries. In angina, it is harder for blood to get through the artery. And in heart attack, plaque cracks and blood clot blocks the artery. What are the symptoms of angina pectoris? A pressing, squeezing, or crushing pain, usually in the chest under your breastbone. Pain may also occur in your upper back, both arms, neck, or earlobes. Pain radiating in your arms, shoulders, jaw, neck, or back. Shortness of breath, weakness and fatigue. Feeling pain, faint. Management of angina pectoris. Give the patient anti-anginal drug, usually 0.5 mg of glyceryl trinitrat sublingually or nitroglycerin glyceryl trinitrate spray 400 mg gives rapid relief. And if there is no relief within 3 minutes, the patient has probably had a myocardial infarction and then necessary to call for ambulance. So we proceed with myocardial infarction. A patient typically has severe chest pain, but may suddenly lose consciousness as a result of myocardial infarction. Myocardial infarction is a common cause of death and must be recognized as the patient's fate may be decided by the first few minutes of treatment. Several aspects of dentistry, particularly apprehension, pain, or the effect of drugs, might contribute to make this accident more likely in a susceptible patient. Typical signs and symptoms of myocardial infarction. Severe crushing retrosternal pain, shallow breathing, vomiting, weak or irregular pulse. As well, it can be accompanied by anxiety, crushing chest pain, left arm pain for men, arm, back, jaw pain for women, diaphoresis, nausea are one of the symptoms of myocardial infarction. And we proceed with cardiac arrest. Cardiac arrest can follow myocardial infarction or the acute hypotension of an anaphylactic reaction or of corticosteroid insufficiency. Otherwise, it may be the result of an anesthetic accident and due to hypoxia, anesthetic overdose, or severe hypotension. Signs and symptoms of cardiac arrest. Sudden loss of consciousness, absence of arterial pulse, the carotid artery anterior to sternomastoid should be felt. Respiratory arrest and eventual cyanosis, pupil dilatation and loss of reaction to light, and absence of measurable blood pressure are other signs, but resuscitation must be started before they develop. Dentists, dental nurse should be aware of emergency condition and alert to the possibility of cardiac arrest and be able to recognize it and manage it when it happens. Speed of response is essential, and there is a legal obligation that the dental team should be trained in cardiopulmonary resuscitation and be able to carry it out immediately. So let's proceed with seizures. Patients who convulse in dental office generally have a seizure history and are often characterized as having epilepsy. Management. If the patient's experiencing seizure is unconscious, they should primarily be placed in the supine position and the head, tilt, chin lift maneuver is performed. Dental specialists should remove all instruments from patient's mouth and protect the patient. Clear airway, loosen clothing and help patient breathe adequately. If seizure continues for long, then the condition is known as status epilepticus. This is a life-threatening emergency and is best managed with intravenous diazepam 5 mg intravenous or intramuscle, or by maintaining till the patient is shifted to emergency medical care. The signs and symptoms of epilepsy include: is defined as a continuous clinical or electrical seizure activity or repetitive seizures with incomplete neurologic recovery interictally for a period of at least 30 minutes. The patient may have an aura or premonition that the seizure is about to occur. Tonic phase, loss of consciousness, patient becomes rigid and falls and becomes cyanosed. Clonic phase, jerking movements of the limbs, tongue may be bitten. Frozen at the mouth, urinary incontinence. Management of a patient with epilepsy. The aura of the patient should be recognized and the ongoing dental treatment should be discontinued. Patients should be placed in supine position with feet elevated. Airway, breathing, circulation should be maintained. No attempt should be made to hold the patient's extremities in a fixed position because of the risk of bony fractures. The head must be protected from traumatic injury through placement of a thin, soft item, blanket or jacket beneath the head, ensuring that the head is not flexed forward, obstructing the airway. The headrests on most dental chairs are normally well padded so that no additional protection is necessary for the head. Any additional pillow or duff nut device should be removed. Removing the headrest permits extending the neck, lifting the tongue, and creating greater airway patency. Hypertensive crisis is another entity that should be discussed in this lecture about medical emergencies in the dental office. A hypertensive crisis is a sudden, severe increase in blood pressure. The blood pressure reading is 180-120 millimeters of mercury or greater. A hypertensive crisis is a medical emergency. It can lead to a heart attack, stroke, or other life-threatening health problems. Severely high blood pressure can damage blood vessels and body organs, including the heart, brain, kidneys, and eyes. During a hypertensive crisis, the heart may not be able to pump blood effectively. What are the causes of hypertensive crisis? They include forgetting to take blood pressure medication, suddenly stopping of certain heart medications such as beta blockers, medication interactions. I highlight it in the red color to indicate its significance. Tumor of the adrenal gland, and so on. Clinical manifestations of hypertensive crisis: blurred vision, chest pain, confusion, nausea and vomiting, not responding to stimulation, seizures, severe headache, shortness of breath, anxiety. Suggested management. The first-line treatment for hypertensive crisis will typically be intravenous antihypertensive medications to lower the person's blood pressure. Healthcare providers usually aim to reduce blood pressure by no more than 25% of trusted source in the first hour, as rapid decreases in blood pressure can cause other problems. Once a person's blood pressure is under control, the healthcare provider will usually switch to using oral antihypertensive medications. The drugs of choice in treating patients with a hypertensive crisis and eclampsia, preeclampsia are hydralazine, levetiracetam, and nicardipine. Angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, direct renin inhibitors, and sodium nitroprusside are contraindicated in treating such type of patients. And we proceed to local anesthetic toxicity. Local anesthetics are the most commonly used drugs in dentistry. Toxicity is usually either due to the local anesthetic itself or the vasoconstrictor, which can be due to rapid infusion or failure to aspirate before injection. Generally, the reactions are self-limiting. Toxicity presents with talkativeness, slurred speech, anxiety, confusion, drowsiness, or even seizure and cardiac arrhythmias in extreme cases. Management of local anesthetic toxicity. Stop the administration of injection and monitor vital signs. Administer oxygen, and in adverse cases, administration of diazepam 5 mg slowly is advised. The next essential condition that should be discussed in this topic, medical emergency, is anaphylactic reactions. Anaphylaxis or anaphylactic shock is a type of allergic reaction where the immune system has a severe, potentially fatal reaction to otherwise harmless substances from the environment. Reasons for anaphylactic reactions in dental office. So it is a hypersensitive state that results from exposure to an allergen. There are a number of dental-related causes, including mouthwashes, for example, chlorhexidine, local anesthetics, latex products, and antibiotics. The most common allergen in a dental setup is latex. For example, latex gloves or rubber dam, cofferdam plates. What is the mechanism of anaphylaxis? Allergic reactions are exaggerated sensitivities, hypersensitive reactions that occur when your immune system responds abnormally to common substances. The reaction begins within minutes, 15-20 minutes, or even seconds of exposure, and they can quickly lead to airway constriction, skin and intestinal irritation, and a change in a heart rhythm. In severe cases, it can result in total airway obstruction, shock, and death. An allergic reaction begins when you touch, inhale, or swallow an allergen. In response to this trigger, the body starts making a type of protein called immunoglobulin E. And this leads to the release of some chemicals, such as histamine, in the body from mast cells. They are a kind of white blood cell found in large numbers in the tissues that regulate exchange with the environment, like the airways, digestive system, and skin. Signs and symptoms of anaphylactic reaction. Manifestations vary from a mild form where the patient presents with erythematous rash, cyanosis, nausea, vomiting, tachycardia, urticaria, or angioedema, to a severe form which leads to airway obstruction or inadequate blood pressure and blood flow to the brain, which is a life-threatening situation. On this picture, you can see schematic representation of the areas to be observed for signs and symptoms of anaphylaxis. Pay attention to hives, loss of consciousness, swelling of tongue, inability to swallow, and rapid swelling of throat tissues. So all of that are symptoms and signs of anaphylaxis reaction. Signs and symptoms of anaphylaxis include skin reactions, including hives and itching, and flushed or pale skin, low blood pressure, hypotension, weak pulse, rapid heartbeat, constriction of the airways and a swollen tongue or a throat, which can cause wheezing and trouble breathing, a weak and rapid pulse, nausea, vomiting or diarrhea, dizziness or fainting, swelling of your mouth, hives, clammy skin, confusion, and anxiety. All are the possible signs and symptoms of anaphylactic reaction that is very typical in the dental office. Management of anaphylaxis. Management involves lying the patient in the supine position with leg raised, then administer oxygen, and the drug of choice being 0.5 milliliter of 1 to 1000 adrenaline intramuscle or subcutaneous. Providing emergency care in dentistry. The dental team must be able to respond effectively and manage the life-threatening situation appropriately. The timely administration of adrenaline is life-saving. Any delays can lead to a poor outcome. And we proceed with Quincke's edema. Quincke's edema, also called angioedema, it is a swelling that affects deeper skin layers, often around the eyes and lips. In most cases, the condition is harmless and it's treated with antihistamine medication. Reasons of angioedema. Quite often, the cause of Quincke's edema is not found. It may be the result of an allergic reaction during which histamine and other chemicals are released. Many medicaments can cause edema, including non-steroid anti-inflammatory drugs such as ibuprofen and naproxen, calcium channel blockers, corticosteroids like prednisone and methylprednisolone, pioglitazone and rosiglitazone, pramipexole, etc. Clinical signs of Quincke's edema. Angioedema of the skin is no pitting with ill-defined margins. Skin is swollen, tender, and warm. Frequently, a burning sensation is present, but pruritus is typically uncommon. Fewer mast cell and sensory nerve ending. Attacks of angioedema may last a few days and usually resolve spontaneously. Swelling of the face, lips, and tongue for the first few hours is expressed. Clinical manifestations of angioedema. In severe cases, stridor of the airway occurs with gasping or wheezy inspiratory breath that sounds and decreasing oxygen levels. The pain associated with these swellings varies from mildly uncomfortable to agonizing pain, depending on its location and severity. Intestinal obstruction may result from angioedema of the wall of the gastrointestinal tract. Nausea, vomiting, and abdominal pain may be severe at times, mimicking acute abdomen, rarely diarrhea. Diagnosis of Quincke's edema is made on the clinical picture. Routine blood tests, complete blood count, electrolytes, kidney function, liver enzymes are typically performed. Mast cell tryptase levels may be elevated if the attack was due to an acute allergic anaphylactic reaction. Prick test or scratch test, also known as a puncture or prick test, and this test is done by placing a drop of a solution containing a possible allergen on the skin, and a series of scratches or needle pricks allows the solution to enter the skin. If the skin develops a red, raised, itchy area called a wheal, it usually means that the person is allergic to that allergen, and this is called a positive reaction. Intradermal test. After examining and cleaning the skin, a small amount of the allergen is injected just under the skin, similar to a tuberculosis test. During this test, a small amount of the allergen solution is injected into the skin. An intradermal allergy test may be done when a substance does not cause a reaction in the skin prick test, but is still suspected as an allergen for that person. The intradermal test is more sensitive than the skin prick test, but is more often positive. In people who do not have symptoms to that allergen, so-called false positive test results. Treatment of angioedema. In the case of acute angioedema, antihistamines, for example, ranitidine, Zantac, anti-inflammatory medicaments, for example, corticosteroids, epinephrine shots, Inhaler medicaments that help open up the airways should be given to the patient. Emergency care in angioedema cases. In some cases, the uvula may become so swollen as to impede the passage of air and cause obstruction and breathlessness, and this requires immediate attention to the airway for relieving the blockage. Thus, intravenous administration of histamine receptor blockers, both histamine 1 and histamine 2 blockers, as well as corticosteroids, is typically prescribed to reverse the inflammation. In general, steroids with a long duration of action and powerful anti-inflammatory effects are given. And we proceed with hemorrhage in the dental office. Hemorrhagic disorders, though uncommon, should always be considered as dental specialists deal with blood routinely, and there are instances when significant bleeding could lead into an emergency. Emergency management begins by gently cleaning the mouth and locating the source of bleeding, and the application of cold compress, pressure packs, or styptics. Suture the area under local anesthesia when necessary. Tranexamic acid, 500 mg in 5 ml by slow intravenous injection, is the drug of choice. Reasons for hemorrhage in the dental office. Post-extraction bleeding may be recognized. Frequently encountered complication in practice, which is defined as bleeding that continues beyond 8 to 12 hours after dental extraction. The incidence of post-extraction bleeding varies from 0 to 26%. If post-extraction bleeding is not managed, complications can range from soft tissue hematomas to severe blood loss. A major vessel is unlikely to be opened during dental surgery, and patients are unlikely to lose any dangerous amount of blood if promptly managed. Post-extraction bleeding is usually only an emergency in the sense that the dentist may be woken up at 3 o'clock in the morning by a frightened patient. Local causes of bleeding include soft tissue and bone injury. Systemic causes include platelet problems, coagulation disorders, or excessive fibrinolysis. Prolonged bleeding is usually due to traumatic extractions of impacted wisdom teeth or a gum graft surgery. Occasionally, bleeding is due to unsuspected hemophilia or other hemorrhagic disorders. So these are the reasons of hemorrhage in the dental office that should be considered. Management of hemorrhage. Dentists are successfully using blood stoppex hemostatic gauze to stop extreme bleeding during extractions and other surgical procedures. Less expensive and easier to use than other products. Bloodstop and bloodstoppex hemostatic gauze stops bleeding instantly and creates a protective barrier over the affected area. Bloodstoppex works by speeding coagulation, expanding to form an odorless and tasteless gel that adheres to the surface and applies pressure to seal the wound. Made from biologically inert, natural regenerated cellulose, bloodstop interacts with blood platelets and fibrin to form a gelatinous, clear shield to create a gentle back pressure and seal the wound. In conclusion to this lecture, it is worth to mention that every dentist should have the essential knowledge to acknowledge, assess, and manage a potentially life-threatening situation until the patient are often transported to a medical facility. Successful patient management relies on understanding the pathophysiologic processes and how to correct them. The most common medical emergencies in the dental office are syncope, adverse reactions to local anesthesia, grand mal seizures, angina pectoris, and hypoglycemia. A dentist must be familiar with the prevention, diagnosis, and management of common emergencies. He or she should be adequately trained so that they know what to do and act promptly in case of untoward event. References to this lecture are available in this list. You can follow all of the information listed here to go in deep into the topic. Questions for self-check? Thank you for being with me on this lecture. Wish you a good day and good luck in the study.